then you have beads that not only have a core, but they have a protective coating, they have membranes that dissolve at different rates. And so the drug is released in small amounts all throughout the day. This is like eye candy to a pharmacist. Isn't it fantastic? Someone figured that out? I think it's just marvelous. So if you look down under the sustained release capsules, you'll see Ritalin LA, Metadate CD, Abtensio XR, and Quilivant XR. Look on those. You'll see that the percent of immediate release differs in all of those. So that tells you that if you, depending on how the child's core symptoms are at the beginning of the day, then they may need more or less of the immediate release. If they're really symptomatic through the day, then you can reduce or you can up the amount of long-term. So lots of ways to address how a child's symptomatology is controlled. Most of these will last about 8 to 12 hours. So if you give them in the morning, they should be able to go through the school day without a repeat dose. That's your goal. Okay. All right. Another one that I love, oh, this one, I just think it's cool. Okay, so this is the Oros is the delivery system, so it's a patented system, and then you've got Concerta, which is the brand name for this methylphenidate. So what it does is once you get it into the digestive fluids, then you get water that will move in. So you've got a push compartment, you've got a drug compartment, and you have an overcoat. So when water moves into this, that push compartment expands and it pushes the drug out. But you've got pores that are limiting, so they are going to limit how much of that drug can get out of those pores at each point. So another different delivery form that has allowed for the ability to release drug quickly and long-term in the same dosage form. Love it. Okay. If you go down to the bottom of underneath that picture, you'll see you've got oral suspensions. You even have oral suspensions that are short-term, long-term. Amazing. Even your orally disintegrating tablets are quick action and long-term effect. Amazing. So the Quilivant is a racemic mixture of the D and L isomer. So they both have different characteristics in different potencies and different onsets. So it's a little bit slower, so you'd have to take that into account if you're going to use a liquid, is that its onset is about an hour. So you'd have to dose it accordingly or administer it accordingly based on that. There's also a patch. So the patch can be used. You can't get it down the kid any other way. You can use a patch. It has some very unique side effects we'll talk about in just a little bit. Its onset is delayed, again, like the liquid. So if you're not putting it in the mouth, or a pill or a tablet or a capsule, then you're usually got a little bit delayed in onset. The good thing with this is you can remove the patch if if your length of time is too long. Let's say the kid is not sleeping at night. You can take this off earlier. Still has drug effect for about 3 hours, but you can terminate effect, whereas if you put it in their body, you can't terminate effect. So that gives you another flexibility there. The one thing is never cut it. So sometimes parents will be inclined to, the dose is too high, we're just going to cut it. Okay? One of my sayings is always never manipulate a dosage form unless you know you are not changing the integrity of it. There's pharmacists, call them. If they don't know, call another one. Call the drug company, they'll tell you as well. So don't cut a patch. Questions about those?
Is it beneficial to use a patch to kind of estimate the effect
No.
it's going to have on them?
I would say most people don't do that. They would go to a, it just depends on when the symptoms are occurring. Usually they'll start off with a rapid acting. And then as they dose titrate and they figure out where the drug is needed and the amount that it takes, they'll convert it to a long acting. So if you look, I don't know what page, it's 8 on mine, you see this picture. So the stimulants, methylphenidate, we'll see also with the amphetamines, they are good at modifying all core symptoms. So they will improve inattention, they will decrease impulsivity, and they will settle the kid down. It's amazing that a stimulant will actually calm people down. So they're both of these. So the other type of stimulant are the amphetamines. They've been around for, since 1930s, a long time. You can give them as a single salt, like dextroamphetamine or amphetamine sulfate, or you can do a mix. Or you can use a prodrug, which is what Vyvanse is. This dexamphetamine is a prodrug. It was developed in order to get around drug abuse. And a lot of these long-actings were developed to get around drug abuse or drug diversion because you can't modify them as easily. You can't take them and do something with them, melt them down, then shoot them up. So that one is also on the market. If you look down through these, you will see the same thing you saw with methylphenidate. Lots of dosage forms, lots of variations in rapid and long-term mixes. The one thing under that you can do with the amphetamine capsules is you can break them apart, sprinkle them on food to administer them, if that works better. So that's a difference. Their onset is about the same we see with methylphenidate. It's pretty quick, within 20 or 30 minutes, always within an hour. And they last about the same amount of time, up to 10 hours. So all those long actings are in that 8 to 12 hour range, and all of them then will get a kid through school. Okay, so Adderall, very similar. It's an amphetamine. You see the very same thing with it. This is the capsule. You've got immediate release beads and layers that then take a while for them to absorb and delay the release beads. So it's the same type of approach we saw with the methylphenidates. So that's good. You don't have to learn a lot of differences with those two groups. In general, their side effects. Oh, wait, let me go back up with products. So you've got a extended release amphetamine suspension, which is Dianabol, and you also have Adzenys, is that the name of it? I'm not very familiar with it. There's also an oral disintegrating tablet of the amphetamines as well. Onset of action, 60 minutes, takes a little bit longer, and then about 10 hours in terms of time. So I would learn those general time frames. Okay. You don't have to learn the mixes. I want you to know more the concept of the different products. In general, adverse effects, the biggest thing is weight loss. So most of these kids will lose weight. Preschoolers, younger kids tend to have more problems with this than older kids. Sometimes weight loss can be a sign that the drug is effective, though. So you can use it as a monitoring parameter as well. And I'll tell you some things you can do to help get kids to eat more when they're on the drug. Let's see, page 9 for them, you're still, I think, I'm on the next page, but I think still on 9. Other common side effects, anorexia. So they don't want to eat, they don't have an appetite. So these are the drugs that are in the old weight loss programs. Some of them like Tenuate and phentermine. All of these are amphetamine-like products. So weight loss, poor growth and weight, poor acceleration of height. So one of the things you will monitor with these kids is their height, and they usually have a slowing of height. They usually reach their adult height, but it's slow. So it's one of the things you'll monitor, one of the things you will prepare the parents about is a slower growth. Sleep disturbances, that's really common. We'll talk about some things you can do there. That often can do a manipulation of dosing, of how you dose in the evening time if the child needs another medication. So those are really, really common. Those would be things you would talk about. and probably things parents would bring up because they will be more unusual and disturbing. Jitteriness, so some kids, especially if they're taking a rapid acting, when it hits that peak, they'll have that feeling of jitteriness, and then that usually will smooth out. Emotional lability. So that may be hard to discern from their underlying condition. Okay. Questions about those? So this is why we don't start with the patch. It has a very unusual side effect in that it has you develop a leukodermia that's permanent. So they lose functioning of the melanocytes in the skin, and it will never change. Can't reverse it. So that's one of the things to tell people about that are going to be on the patch is that any sign that that's occurring, they need to stop the drug and let you know. They usually occur where the patch was applied, but not always. Sometimes it'll occur in another part of the body. That would be more unusual. Rotating sites is something we still recommend they do, but it doesn't mean it will prevent this from occurring. It would always be an indication to switch. You would not continue, is the recommendation. In terms of cardiovascular effects, these you should be able to predict. So blood pressure goes up, heart rate goes up. Probably gives them some to the, adds to the jitteriness. So this is one thing you would also monitor when these kids come in, and they'll come in frequently in the beginning, is blood pressure and also and their heart rate. Priapism is a rare complication, but one you need to keep in mind for boys. It can occur on the stimulants and the non-stimulants. So it's an erection that usually lasts for 3 to 4 hours. Sometimes it will not go away and they'll have to do surgery. So it's considered a medical, not emergency, but urgency is to get them in for somebody to address that. And that usually will require a discontinuation of the drug, a switch. You could switch to a non-stimulant, but they can do it too. So there's, thankfully it doesn't occur in very often. Tics. So kids that have ADHD are usually a higher percentage of them will also have tics. They can get better on drug, they can get worse on drugs. Sometimes if they really worsen, what they'll recommend is a drug holiday, take them off of it so you can figure out, is it really the drug or is it the underlying other conditions that they have. Some of them, for some of the drugs, it will be a contraindication to putting them on, or if there's a family history of tics. So you kind of have to be drug specific for that. Diversion and misuse are a major problem. And one thing too is to have conversations with the parents, and as the child grows older, about how people may approach you for medications and what do you do and how do you respond. One of the things is just keep them out of school. Keep them out, keep the drugs out of the school yard. But two different definitions there. Stimulant diversion is where you're giving it to another person, but stimulant misuse can also occur. So this is where the kid takes a higher dose. So they're taking a higher dose either to get higher effects, combine it with other medications. So two different ways. So a child, the user can do it, or they can give it to other people. I included this the results of the systematic review because I thought they were pretty telling. They looked at children. They asked kids, you know, how often are you approached to get a drug, or to have someone sell it to you, or just to give them a tablet. So 5 to 9% of grade school kids and high school kids and 5 to 35% of college-age kids reported non-stimulant use in the year before the study. These are kids that weren't prescribed the drug. The proportion of students with stimulant prescription who were ever asked to give it to somebody or to sell it to someone is up to about 30%. So that's why it's important to have that discussion with kids. Rehearse it with them. Someone comes up and asks you for your medication, what are you going to do? It's more common with the immediate use, that's why we don't use them very often anymore. And we use the longer term, that's why a lot of those have come about, so it's to decrease that diversion. Most common reported reasons for using them is studying, staying awake, improved alertness, experimenting, getting high. Things that you all have actually reported in your, when we begin the class. Comments on those? The biggest part of one of the things here that will be a big help to you is your pharmacist. So you're always looking for adherence or non-adherence, and non-adherence can be overuse as well as not using. So finding out when the prescription was written, or when it was filled, and then correlating that with use, or their reported use. So Schedule 2s, if I remember right, have to be filled within 72 hours, so people can't hold on to them. And they have to be done in 30 days. They can only give them a 30-day supply. So I guess they have to come back for a new prescription every month. That I didn't check on, but according to the Schedule 2 guidelines, that would be correct. Contraindication to stimulants would be symptomatic cardiovascular disease. That would make sense. Blood pressure. So think about the side effects, and I'll give you a lot of the contraindications. Hyperthyroidism, that would be just cruel and mean to put them on that if they were controlled or being treated. Known hypersensitivity to the medicines, motor tics or Tourette syndrome, glaucoma, agitated states, anxiety, history of drug abuse, family history of drug abuse. There's people in the family or associated with the family that have known drug abuse, that would be also. And then concurrent use of an MOAI in 14 days. Okay, comments or questions about the stimulants? Okay. Let's look at atomoxetine or Strattera. This is a non-stimulant. So this is it's not a scheduled drug. It's a selective norepinephrine reuptake inhibitor. So you remember when norepinephrine is released from the presynaptic membrane, it travels across that synaptic cleft, interacts with a receptor, and then you've got all these enzymes in the middle that are trying to chew them up before they can do any more work, right? And then you've got these reuptake receptors on the presynaptic membrane, and they take up any extra. So you got multiple ways to get rid of or terminate the action of norepinephrine in that synaptic cleft. So this drug sits on those reuptake pores or receptor channels. Can be used in any age group, the kids 6 and older. It's an alternative to a stimulant. It would be unusual to start with these or second line unless you had a contraindication to the stimulants. They are usually dosed once or twice a day. They usually have fewer side effects. We usually don't have to do drug holidays with them that we sometimes do with the stimulants. I'll talk about those in just a little bit. They are weight-based. I think the cut, or it's 70 kilos less, 70 or more than 70 kilos is the change in dose. They do have a different metabolic pathway, the 2D26. So some of your antidepressants will interfere with the metabolism. In terms of side effects, different. So here, weight loss is still a problem. But then the other two are GI and CNS. So GI are decreased appetite, we saw that. Probably not to the extent you'll see with the stimulants. Vomiting, nausea, upset stomach. The CNS, you can see these with the stimulants as well. Headaches, dizziness. Here's sleepiness or fatigue would be a different one, and irritability. It does stimulate the cardiovascular syndrome, so it does have a risk of sudden death. So evaluating the kids before starting them on any of the drugs would be warranted because they will all affect the cardiovascular system. Priapism is also a problem with this drug, so keeping it in mind when you're talking to the parents of a boy would be important. You see the black box warning either on the next page This one is for increase in suicidal ideation, and there's been an increase in suicidal thinking, ideation, and also increase in suicide. So being careful, talking to the parents, doing a good history. That's why that psych is so important, not only to treat concomitant disease, but also in terms of the impact of these drugs. And liver, more liver effect than you'll see with the stimulants as well. So you can see hypersensitivities or severe liver impairment. So warning them about those kinds of symptoms and to report them right away. Contraindications are, again, those monoamine oxidase inhibitors. That's going to be true for all of these. Glaucoma, history of pheochromocytoma, so really similar to what we saw with the stimulants. Here they are more specific on cardiovascular disorders. So if an increase in blood pressure of 20/15 or an increase in heart rate of more than 20, if that would be detrimental to their cardiovascular system, then that would be a contraindication. So these would be kids who would already have disease or some type of cardiac anomaly. Questions about Strattera? Okay, let's go to the last two. These are more uncommonly used. They are usually second line. They would probably be considered adjunct. It would be rare that you would use them by themselves, even though they can be if you don't have any other drug to use. If you have people who can't tolerate stimulants to the full dose, you can add these adjuncts on, or you can use them to modify for mostly ADRs, or if they do not respond fully to a full dose of stimulant. So the two that are out there are clonidine and guanfacine. These both target the postsynaptic alpha receptors. So they actually are agonists. They sit on the receptors, and so they act like norepinephrine. The two things to remember with these is that they are delayed in onset. So with the stimulants, the day you give it, you will see a change in symptomatology. With these drugs, it can take up to a couple of weeks for you to see full effect of the dosing. The other thing to remember is that you cannot stop them abruptly. So this is true with clonidine and blood pressure, also true with guanfacine. You will get a rebound in hypertension. Blood pressures can go way up. So these need to be tapered off. So those are really important things to keep in mind. Delay in onset of efficacy always have to be tapered. I'm not worried about you knowing the dosing. They require a titration up. They're very, clonidine, dry mouth, makes you sleepy. So kids that are very stimulated by using the methylphenidate or the amphetamine, sometimes they'll use this at bedtime to help with sleep. Okay, this is probably where your handout and mine divert. Let's see if there's anything else. Okay, let's go on over to treatment with medications. The goal of therapy is behavior. So the goals need to be set in very strict behavior terms. Can sit in their seat, can go to work and not miss work, can hand in their papers on time, can get assignments done on time. Okay, so those would be really specific. And those will help you in terms of figuring out if the drug is working or not. Some patient education, so prerequisites you can mark out. If you want to compare your handout to what's online, you'll have a better idea of what I'm asking you to be responsible for. So the prerequisites, you're not going to work these folks up, that you will see them on the other side, more than likely. Lindsay and I had a conversation during the break. She worked in a pediatric group, and she said that the pediatric people did work these folks up. So in our discussion, it may be that more in their residency training they cover a lot more behavioral medicine, because it is hard to get people into psychiatric or get them in with a psychiatrist or a psychologist, for especially cognitive behavior. I called around, was looking for a patient to get in, and they're just booked out forever. So she made the comment that they do work these up, so you're likely, if you work in a pediatric group, to see this. You said the workup was about an hour?
Yeah, I mean, we allowed at least an hour for new patient ADHD visits, and I mean, yeah, it was a crazy one. They typically went over. I mean,
And you said there was a lot of demand for that.
Yeah, so our 11 o'clocks and 4 o'clocks were always held for behavioral medicine.
Every day?
Mhm.
Every day?
For our doctors.
Wow.
Med levels would never see them, even
Okay.
just in the, like, in-between management.
How many pediatricians did you have in your group?
There were like 6 pediatricians in 3 different offices, and then multiple med levels per office.
Wow. Quite a demand. Under pre-treatment education, there's some things that I drew from that I think are good for patient education. One is to always go over with them about expectations of a drug. This is true with almost any time you're using a drug, is what should, because sometimes the patient's expectations of what they should get out of it and what they're getting out of it will not match. So, going over that with parents in particular, and with the kids, depending on their level of understanding, is what can they expect. The other is to review the adverse drug reactions. So that the parents will know, some of them they need to report to you, some of them they need to realize that this is an indication the drug is working, and here's what you need to do. And we'll go over that in just a bit. Also going over process with them so that they understand, like Sophie said, okay, the kids, they've got to fill them every month. You'll have to come in frequently for either lab or evaluation early on. Once they get them to maintenance, they will go longer. But going over that process so they'll know. Because if you're dealing with kids, then it's impact on school, it's impact on the work of an adult or the parent. So it's those frequency of follow-up. Some of it may be done by phone calls, behaviors that the family should note, in that they should report. Also, getting the communication from the teacher, what is going on, so the teacher knows what to evaluate and what to report. So three stages in dosing these folks, or in action. So I've moved to dose titration. So you can ignore choice of agent, you can ignore general considerations, you can ignore choice among stimulants, preschool children, and I have moved on to probably page 16. At the top it should say dose titration. So there's a period of titrating them, usually it takes a few months to figure that out. Then there's the maintenance phase, and then there may be a termination phase. After a number of years, they may come to the point where they decide to take the person off therapy and see how they do. Let's see. Monitoring, we've talked about those things that you should monitor every time they come in. One thing that I think is smart is start on a weekend, the drug, so that the parents can observe them, get some feel for it before they start sending them off to school. Kind of some developmental things. Children should not administer their own medicines. I've given you in other disease states where I have found that to be the case. You really, if the parents, maybe it's their first child, they really don't know what to expect. Maybe their parents were very high expectations and they had to do stuff, and then transferring that kind of responsibility to a kid, it's really important to be developmentally appropriate when you're looking at medications. Even with adolescents, you have to at least have some type of oversight. So as the child increases in independence, you need to transfer some of those things with oversight. Some parents will cling to it too much and not allow the child independence, and some will be too freely giving. So going over those parameters, talking to them about, okay, it's probably time to let them take it during the weekend. You start with small things, and then as they gain responsibility, then loosening that up and transferring that. Let's see. The regimen, again, is determined by the core symptoms and occurrence of side effects, and so that goes to the matching up of the dosage form with how the child behavior exhibits. So again, they usually start with those rapid acting and then move to a long acting. A couple of things to keep in mind: a high-fat meal will delay absorption. So having them stay away from that at least on the time that they take the pill. Appetite suppression, warning patient, this will be, it will kill their appetite. They will not want to eat. So warning parents about that, but also as an indicator of effect. Under monitoring response, which is probably page 17 for you all, you're going to monitor the core symptoms. That's why it's so important to document. These are, under those domains, these are the things where they're having trouble. Impulsivity, hyperactivity, inattention. Okay, and that's what you're going to look for response. Your teacher, again, is one of your key people to get their input because they see the kid all day long. Okay. So teacher feedback. Managing stimulant adverse effects, that's the bottom, I think, of 17 for you all. So some tips, some things to do. One is to take the drug after they eat so they can get some food in. Noontime tends to be the hardest time to get kids to eat because their appetite is killed. So what they recommend is get planned foods that they like. Okay? So that's when they get to have the things that are maybe a little bit more indulgent, or their favorite foods when they're more likely to eat them. And then being careful with those high fat content like this McDonald's meals that you see the child eating there in the picture would delay onset. Next page on poor growth. So drug holidays usually are not, we don't use them unless we have to. So a drug holiday means you come off the drug for a period of time. So really the only indication with the stimulants for a drug holiday is poor growth. So you know you're charting, and you've gone over growth charts, so you know that we chart children's height and growth, and kids follow their growth chart. And moving off of your curve is usually an indication that something is going wrong. So for this one, it's moving 2 lines over. So if you're a 90th percentile and you've moved, what's the next one, 75 and 50? If they have moved that far off of their growth curve, that is an indication for a drug holiday. And looking at putting them on either a different drug or a different combination or a lower dose. Dizziness, so monitoring blood pressure, heart rate is important. Trying a longer acting prep, it's probably related to peak effect. Nightmares are a problem with these drugs, so sometimes knowing when they're dosing them, looking at moving a shorter acting away from bedtime. Good habits, so you may have families where the kids go to bed at all different times. I'm telling you right now, kids are happier if you put them, and you will be too, if you put them to bed at about the same time. You establish a routine and you go through it every time. That way the kid knows it's time to go to bed. We brush our teeth, we read a book, say our prayers, get in bed, lights go off. Whatever you decide happens, that's important, and keeping that time. The body will do better, the kid will do better, you will do better. If it's still a problem, then it may be a need to shift when that shorter acting drug is having effect. Mood lability also goes to peak effect, so that's why it's important even for the teacher to tell you that. You give them 30 minutes or an hour before they go to school, their peak effects are happening right about the time they get to school. Rebound is those symptoms occurring before the next dosing interval. And sometimes those will occur over time. The longer they take it, you may see rebound more often as you're getting maybe to 5 o'clock in the afternoon. Maybe you see it because on the drive home, those symptoms are starting to come back. Or about the time you're having supper. Watching tics. Again, tics can get worse, they can get better. And if they're really predominant or they get worse, then sometimes taking them off the drug, lowering the dose will help you discern whether it is due to the drug or not. Sometimes kids will get psychotic. on these drugs, so that can be a time where you have to go to an adjunct or a mix or a different combination. Again, diversion and misuse, you've got to have those conversations and you have to be actively suspecting it, that it can occur. Any comments or questions? Treatment failure. So kids cannot respond to one stimulant, but they may respond to a different one. So failure on one class does not mean they won't respond to another. So moving them to a different drug and trying that is appropriate. You have to differentiate lack of response from rebound. It just may be that the drug doesn't cover them as long. So there's variations in how fast a drug dissolves, how fast it moves through the GI tract. So differentiating, is it just that the drug isn't lasting as long as we thought it would, or is it the drug, they're just not responding to it? So those are things to discern. If they have side effects on one stimulant, they may not have the same on another, even though they're very similar. So moving them to a different class is appropriate if the side effects are too much. Children who don't respond to two stimulants, then that's the time to start looking at those adjuncts or looking at Strattera as an alternative. At the bottom of my page, under possible considerations under treat failure, always think adherence. If you don't do that next year, I'll be really angry with you because we've talked about it. Non-adherence, you have to, and every time you are evaluating a patient, you've got to figure out, are you taking the drug like I think you are or not? So it's the same here, non-adherence. So you all have given very good personal stories about people who were prescribed those drugs and didn't want to take them. So as they get older, you might suspect that. You may have parents that are very disagreeable with it, they don't want their kid on a drug and they don't want to give it to them. So non-adherence. Medication diversion, so having the parents be hyper aware of that, and always keeping that conversation with the kids. Are their expectations realistic of what should take place and what the drug should do? And whether there is another psychiatric diagnosis that has not been addressed. Okay, so those are your reasons for treatment failure. Changing from one med to another, you can cross out. Medication or maintenance therapy. So this should be the longest life of the drug is where they are maintained. If you have to switch us to another drug, a stimulant or another stimulant or another non-stimulant, you start the process all over again. So you go back into a titration phase and then hit the maintenance phase again. You're still going to do the same kind of monitoring that you have done in the titration phase. Adherence will be one of the big ones in this phase, and the kid is going to grow and they're going to change. So modifying those as the child gets older. The drug holidays, again, are used mostly for the either terrible side effects or the weight is a problem, weight gain, weight loss, sorry. So we only use those for the stimulants and not the other agents. Termination of therapy, it is possible that when a child gets to a certain age and they've done very well, and maybe you've had behavior training in there, and they're doing well, is to consider terminating the drug and see how they do. Again, remember about the ones you have to taper and the ones that you need to, that you can stop right away. Okay, questions? And sorry for the mess. If I look online, get that one off E2L, that's what I'm going to cover on the assessment.